Right. So to introduce our first speaker for today, it is Dr. Prabodhana Ranavira. He will be sharing with us his thoughts on his expertise, in fact, about the updates on the management of postpartum hemorrhage. Dr. Prabodhana is a consultant obstetrician, currently involved in also being a medical educator for undergraduates and postgraduate trainees in obstetrics and gynecology. He's obtained his MBBS from the University of Colombo with multiple distinctions, as well as his MD in obstetrics and gynecology. He did his specialty training at Whipps Cross University Hospital in the UK, and is also a member of the Royal College of Obstetricians and Gynecologists. Dr. Ranavira has completed the International Inter-University Diploma in Benign Gynecological Endoscopic Surgery from France. He's also received the certificate in training in higher education from the University of Colombo with accreditation by the Staff and Education Development Association of the United Kingdom. This was in 2016. He's also a recipient of the Shan S. Ratnam Young Gynecologist Award at the 23rd Asian Oceania Federation of Obstetrics and Gynecology 2013. I'm sorry about that. All right, over to you, Dr. Prabodhana.
Good evening, ladies and gentlemen, and thank you, Shamun, for the kind introduction. So today I'm going to talk to you about a little bit of, now this is something you all know, this is our bread and butter, and I mean, as an obstetrician or even, like a registrar, even a junior doctor, all of us has been trained to manage postpartum hemorrhage, but at a different level, right? So each, from a house officer to a consultant, we engage ourselves in different levels to manage postpartum hemorrhage. So I'm going to just talk about a little bit about postpartum hemorrhage, and as you all know, is one of the leading causes of maternal mortality worldwide, and especially in the developing world. And it estimates that severe postpartum hemorrhage occurs in about 11% of women who give birth, and according to WHO, 25% of maternal deaths are due to PPH and accounting for more than 100,000 maternal deaths per year. And though in the developing world, it's a relatively rare phenomenon. In it's in the developing world, it's a relatively a common phenomenon, but in the developed world, it's a preventable cause of death. And in 2009, that's the latest data I could find about the statistics about individual causes, and 29 out of the 134 deaths, which is about 21%, have from our deaths occurred due to severe postpartum hemorrhage. And mind you, according to the developed world, these deaths could have been prevented. So now, the first thing when somebody is talking about postpartum hemorrhage, we need to know, how to diagnose. What is the definition? Now, sadly, when I went through, as we all know, now depending on the college and SLCOG has its own definition, and RCOG has its own definition, ACOG has its own definition, the FIGO, which is the 2022 guideline, has its own definition, right? Now, the basic thing that I gather from all those is, if there's a hemorrhage of more than 500 ml, regardless of the mode of delivery, we should be allowed. And now in some guidelines, it's more than 1,000 for a cesarean section, and even sometimes more than 1,000 for a vaginal delivery. Now, the basic principle is that where there is an ongoing bleeding, regardless whether it's going to be 500 or less or even more. If there's ongoing active blood loss, we have to be concerned, and we should be, monitoring that patient more, closely, and we may have to activate our postpartum management protocols. And also, any blood loss that has the potential to cause hemodynamic instability should be addressed, because now we know that about 95% of Sri Lankan women have HB of less than 10.5. So when somebody has anemia, their tolerance level for hemoglobin, or what you call postpartum hemorrhage or any bleeding, can be less. So we can't wait for some time 500 ml loss, or we can say, okay, let's wait for 500 ml. Then when the patient collapses, then start our postpartum protocols. We should not be doing that, because if there's tachycardia, tachypnea, if the blood pressure is going down, or we are trying, there's an instability of hemodynamically, we should start our protocols even at a less amount of blood loss. That's important, because that is one of the key take-home messages that I want to give today. Now, prevention also something we should be talking, and as we all know, that active management of third stage of labor can prevent postpartum hemorrhage by 60%. And hence, in countries like us, or in the developing world, it's a universal phenomenon that we don't ask the consent of patient for active management of third stage, right? And I can assure you that all nurses, they can miss a lot of things, but you can assure somebody is with a syntocin on at the time of anterior shoulder delivery. So much so, if there's a twin delivery, you have to remind them not to give of the first baby coming out at the anterior, because that's something in their system, and we want to continue that because it has shown to reduce postpartum hemorrhage by about 60%. So the current recommendation is 10 international units of IV oxytocin during the third stage of labor, which is part of active management of third stage. There's also evidence that the combination, ergometrin oxytocin combination, or oxytocin and misoprostol combination, works better, but at the expense of more side effects. So we have to be cautious, and oxytocin alone works well. It's the first line recommendation. However, we can, in a patient who we think has a more potential for postpartum hemorrhage or high risk for postpartum hemorrhage, we may consider giving a combination of therapy at the time of third stage to prevent postpartum hemorrhage. And one of the other thing is to anticipate postpartum hemorrhage. So we are ready. We are ready with bloods. We are ready with our drugs. And we try to optimize patient beforehand, like patient with anemia. I think Richard is going to talk about more about that. So prevention is one of the key, features because it's better to prevent rather than manage it and easy. So optimizing hemoglobin, patients with grand multiparas and things like, even using proper contraception is also part of this prevention program. And patient with a previous history of postpartum has the highest risk of subsequent postpartum hemorrhage. So we have to be ready for them. Now I'm going to go a little bit of detail into the management, right? And as we all know, it's an emergency. So basic principles like call for help, informing people, getting ready is very important, because it's something that you can't manage alone, right? And we have to stick to our ABC protocols, right? So airway, breathing, and giving oxygen, at least 8 liters via a face mask, and make sure we have access to circulation, IV cannulae. So basic things that we all, from the undergraduate level, we have been assessed, and we continue to assess. It's very important that we stick to basic principles. Now, if a woman is in shock, which we consider as if the heart rate is less than 100 and the systolic blood pressure is less than 90, we have to initiate aggressive fluid replacement. So we have to squeeze saline or ringalactate solutions. And we have a protocol which we have to give 1 liter that is in Sri Lanka, 2 packets, because we have 500 ml salines in 20 minutes. The 20 minutes is the fastest we can give. So we have to have a wide bore cannula, which is we have nowadays the white and the ash one, which we have to squeeze in. Then it will go in about 10 minutes time. So 2 packs in 20 minutes. And we can start the next liter in another 30 minutes. And while we are trying to get our drugs organized in an unanticipated patient, bimanual uterine compression, if the uterus is atonic, can buy us valuable time. Right. So these are the basic things. And as a house officer, also registrar, make sure that investigations are available so that this for the subsequent management, that's very important. And the important thing, start in the medical management, because we can, prevent an hysterectomy or surgical intervention by about 80 to 90% by adhering to a proper medical management. Right. So the first line therapy is oxytocin 10 units IV. And now one of the newest thing is that to give tranexamic acid rather early. Now in protocols is say within 3 hours. In our protocol, which we made for our unit, is our second line drug. If we have to give oxytocin for the second dose of oxytocin after the initial oxytocin at the third stage, if you have to give the second one, if she still continues to bleed, our next drug would be IV tranexamic acid, which she is diluted over 10 ml and run over 10 minutes. And if the repeat, if bleeding continues, then we can give another dose after 30 minutes. Right. We can also start oxytocin 40 units in 500 ml and run 125 ml per hour, so that the 10 unit goes in every hour to keep the uterus contracted over a long period of time. Now, if a patient is suffering from heart disease or any other, like especially patient with preeclampsia, we have to, remember our fluid overload can kill the patient. So before the PPH, pulmonary edema can kill the patient. So we have to remember to reduce our fluid intake despite giving all this, while we are resuscitation. So ergometrin is a third line or second line in our protocols, third line, IM or IV, because we have now 0.2 or 200 micrograms available, and it gives less side effects, and we can give it IV also. But we have to make sure that the patient is not suffering from hypertension or heart disease. And we can repeat every 20 minutes. Carboprost, 250 micrograms IM. And if we are doing a cesarean section, we can even give intramuscularly to the womb, the uterus. And we can repeat every 15 minutes. Again, we have to make sure the patient is not a asthmatic. And misoprostol, 800 PR, 4 tablets, that has shown to reduce, and especially, Sri Lanka also we use it very often, but, countries where oxytocin is lacking, or the cold chain cannot be maintained, it's a miracle drug to save lives. And if we think the patient is bleeding continuously and we are not, we can't handle properly, it's better to transfer the patient to the theater, because if we need to do surgical procedure, it's easier. And also the monitoring part is taken over by the anesthetists, and that they are more, geared to do that, and they will be more geared for resuscitation process. So they will be liaising with us frequently. So because of that, taking her per patient to the theater with the initial resuscitation or initial management fails is very important, rather than waiting until the patient collapses and running to the theater. Right. And using, we know that coagulation get affected with cold infusions. So even whether it's blood, any other solution, if we can run through a warm system, that will help the patient for coagulation. And also when we are trying to give a correct hypovolemia, going for crystallite is better than colloids. And in fact, we as obstetrician, we don't like colloids unless it's really, really necessary. And if a blood transfusion is required urgently and we anticipate a delay, We can give group specific blood or even O negative blood if nothing is available. As I said, colloid expanders are hazardous and it interfere with our the testing and also with blood transfusion, right? And again, one of the new things that we should be, encouraging if the facilities are available is for elastometry or ROTEM guided therapy. So I'll be coming to that. And I think our transfusion medicine specialist will enlighten us more than, so I'll leave that to her. And so it's important that we take a sample at the initial steps once we do the initial resuscitation into a citrated bottle so that we can, have an idea about the thromboelastometry. And it has shown nowadays, especially to prevent overtreatment. And because we know now the blood products are scarce, it's expensive, and there are risk involved in giving transfusion. So because we also have to think about cost, right? We used to give 1-to-1 and everything, and we overtreat most of the time. But the thromboelastometry or ROTEM guided therapy has shown to reduce overtreatment as well as under treatment. So when the facility is available, we have to make use of it. And our transfusion medicine specialists, hematologists will help us with that, right? And of course, ongoing monitoring is very important. And by the time we start anything, if we have forgotten the catheter, we have to start that. It's important to use that. And if we are dealing with somebody who's having really bad, postpartum hemorrhage, and we have done the initial treatment and has gone to the ICU, we have to even think about more invasive ongoing monitoring with arterial lines, CVP lines to guide our fluid and blood pressure management, right? And balloon tamponade, again, now most of the hospitals have the balloon tamponade, the original version of it. As registrars, we all were trained with the condom catheter. And I think Sri Lanka is coming back to that era again. So again, we have to remember how to use, how to make a condom, a balloon tamponade using a condom catheter, which is very cheap. And so that's has prevented about 90% of our hysterectomies. So we have to use it early, but one of the key things to remember is when there is ongoing bleeding, we have to be very cautious when we put in the balloon tamponade. Then if the patient is stable once the postpartum hemorrhage, so one of the other things we have to remember is we forget that they are more prone, though initially they are more prone for PPH. After that, they are more prone for, because of the blood products and dehydration, intravascular, fluid depletion, they are more prone for thromboembolism phenomena. So we have to address that. Usually after about 6 hours, we have to start thromboprophylaxis with stockings initially, and then think of even low molecular weight heparin. So the surgical management, so balloon tamponade, and then if that's not working, or especially if we are in a cesarean section, we can think of B-Lynch sutures, right? There are various methods of doing is if you are close, we can do modified B-Lynch. So there are many methods available. So we have to stick to one and then continue to practice. And one of the things you can do is in the theater, we can have a drawing about how to perform a B-Lynch suture in an emergency. Systematic devascularization, ligation of uterine arteries, ovarian arteries, and of course internal iliac arteries. And in fact, all registrars during their training, they are trained for internal iliac ligation, especially during their cancer appointment, which is something all of you should focus, because that can save lives, especially when you're working in a periphery. You have to perform that by yourself. So that competence is something you really, really need to achieve. And of course, everything else is failing, then you have to do a hysterectomy, but remember to do it early rather than late. Because sometimes we wait because of priming and all that, we wait trying to save the womb, and sometimes in the process we lose the mother. So we have to make sure that if things are not going the way that we plan, to resort to hysterectomy rather early than late. So these are the main things that I need to kind of tell you about. So about the initial adhering to basic principles, like calling for help to manage as a team, and especially with the help of hematologists, transfusion medicine specialist, anesthetist, so that the patients are managed in a more multidisciplinary environment rather than alone, right? And to give prevention and tranexamic acid at early stage, and resource to hysterectomy earlier if we think things are not happening. And one of the key messages is to when you're coming for transfusion, it's better to if the ROTEM facilities are available, to use that to optimize our management. Thank you very much. Questions? Yeah. So I'm happy to answer any questions.
Do we have any questions from the audience? Or for those who are currently listening in via Zoom?
What is the place, right? Yeah, so somebody has asked active management of oxytocin, IM or IV, and it's IV. So soon after so usually after delivering of the anterior shoulder, we have to do it. But I mean, now most of the time people are very vigorous about it and then wait for the anterior shoulder and try to give it. So we'll keep it, but it's not, we don't need to do it that fast, but better to do it, keep it like that. So every time it happens without any issues, right? And what is the evidence for PR misoprostol? So it has been in practice for a long time. When you say evidence, offhand I won't be able to tell, but it has been shown to work in about 60 to 80% of the time in managing postpartum hemorrhage. And in one WHO study sometime back in a very remote area of the world, has shown even where they have no cold chain oxytocin or ergometrin to be stored for like giving sublingual oxytocin after delivery of the baby has shown to reduce postpartum hemorrhage by about 80%. And in twins said to wait cell delivered. Yes, because the third stage starts after the second delivery of the second baby, because once if you give that, the uterus start contracting and sometimes the cervix will start closing and it will be difficult to deliver the second baby. Okay, thank you.
All right. Thank you, Prabodhana, for that very interesting lecture on the update on management of postpartum hemorrhage, and also for taking some of the questions. I know you have a busy schedule today, so thank you very much for dedicating your time towards this program. Right. So moving on, we have next Dr. M.R.M. Rishad, who will be talking to us about about improving the quality of management in postpartum hemorrhage. Dr. Rishad is an honorary consultant obstetrician and gynecologist and a senior lecturer at the Faculty of Medicine, University of Colombo. A little bit about him. He has obtained his MBBS and MD in Sri Lanka and also got a diploma in laparoscopy from France, as well as postgraduate certificate in medical education from Dundee. He is a member of the Royal College of Obstetricians and Gynecologists. And as he's very humble, that's all he has written to us. But just to add on, I know that he has numerous publications and has he's very keen in conducting a lot of research and has got a lot of ongoing projects. And also he's currently pursuing his PhD, which I think is near completion. So over to you, Rishad.
Right. Thank you for your kind introduction, Shamoon. So good evening, everyone. So this is, I'm going to talk to you on quality improvement measures that can be taken to improve the quality of care given during the management of postpartum hemorrhage. We all know that throughout the world, maternal deaths due to obstetric hemorrhage occurs. It's about 1/3 of maternal deaths are due to obstetric hemorrhage, and it is mostly 90%, more than 90% of them are preventable causes. So Sri Lankan maternal mortality statistics in 2020 shows that that is postpartum hemorrhage was the leading cause of maternal deaths in 2010. That is, we have lost 10 or 12 women due to obstetric hemorrhage. And Professor Hemantha Senanayaka reported, he analyzed about 5 years history of maternal near misses that were reported, and he showed that among 58 women, nearly 42 women had hysterectomy due to obstetric hemorrhage. That all these indicates higher rate of maternal mortality and morbidity. All these indicates that we need to improve the quality of care when it comes to obstetric hemorrhage. We all know maternal deaths due to postpartum hemorrhage is highly associated, or it is due to a combination of multiple factors. The leading the causes are poor quality of care given to women during obstetric hemorrhage, and also a reflection of a weak healthcare system. So with that background, I'm going to tell you how we can improve the quality of care in our setting. So I'm going to recap the evidence-based strategies, and mostly Prabodhana discussed about these technical things, and I'm going to highlight some key things that we can do in our setting to improve. So when it comes to quality of care, there are two main things. One is provision of care. That is, we should resort to evidence-based practices when it comes to management of obstetric hemorrhage or postpartum hemorrhage, postpartum bleeders. So evidence-based in the sense, a lot of people, what happens is, we have our audits show that we have not followed the standard protocols or standard evidence-based practices. Like he nicely mentioned the key steps that we can follow or we can adhere to when PPH occurs. So provision of care is one important area. So we have to stick to evidence-based management options. And experience of care, that is also, we often forget the experience of care by the women. So, we have to communicate with the patient and the patient's family, and also communication with the staff members. That is that that comes under this other arm, or experience of care. So both these elements or arms, if we do it very well, that will lead to improved healthcare outcomes, or improved outcomes in the system. So when it comes to quality, one important element is prevention. We can prevent mostly when we know the risk factors. We can take some actions, we can modify the care pathway, and we can make a big change if we correctly identify the women with risk factors. So, and also we should bear in the mind that about 20% of the women don't have risk factors. So we need to anticipate that and be prepared for that. So we know the risk factors. So knowing the risk factors is not enough. We often forget. So when we see them in the clinics, we should correctly identify and highlight, or maybe we should flag it properly. So the Royal College says that risk factors for PPH may present antenatally, or time to time it may change. So during intrapartum, so when we correctly identify the risk factors, we should we should be aware and take necessary actions, and we should inform the seniors, or whatever. We have to adhere to a correct pathway. So prediction and prevention is one important area. So when it comes to the risk factors, hemoglobin, as Prabodhana correctly pointed out, we often encounter women with anemia. So what we do is, in our unit, we did a large level audit, and we found that we have mismanaged mothers with anemia. So we have, we have an antenatal record in which we correctly, we have a checklist like thing in the antenatal records. We identify and we make modify the management plan, and we refer to, if needed, we modify the pathway. We involve the hematologist in the early stages itself. And also, we should, when it comes to management of anemia, we often forget that we don't educate our women correctly. So we have developed a patient care or patient information leaflet regarding anemia. So we have detailed all the diet patterns, and we have tried to make them aware regarding the common myths that they have. And it's a peer-reviewed, leaflet. We involved all the consultants and the hematologist and some trainees, and even it was tested among some mothers and got the feedback. And we have a very good leaflet. So when we find an anemic woman, whenever we encounter them, we hand over a copy of this for them to go through. So this is one: prevention, prediction, prevention, and quality of care require. When it comes to quality, facility readiness is one element, one important thing. So identifying the patients is not enough. So we should be ready. So availability of the staff, key equipment, and drug supplies. So we should have a trash trolley, or we should have or cart, or we have to have some sort of a pack when it comes to an major obstetric hemorrhage. And more than that, we should have a provider preparedness. Our team should be ready for that as well. When it comes to skills, we often we need a refresher training programs, we need drills, and to deal with PPH. These are some of my experience as well. When we teach them for some time, that will retain, and we have to have regular refresher trainings to keep the providers ready, and also keep the unit ready. So otherwise, we may often, frequently we give a poor quality of care. When it comes to provision of care, we often fail to provide the best standard of care, even though when it is easily given to our patients. So each unit should be ready with either protocols or guidelines, or even simple checklists to improve the quality of care. So we have, we have enough evidence to show that in units which have evidence-based guidelines, can give an improved quality of care to their patients. That's why in developed countries, all the units have well developed protocols. So to having identified the gap, we also developed our own protocol. We have a national guidelines. So what we did was we did a literature review, and our team formulated that actually postpartum hemorrhage protocol was developed by Dr. Prabodhana, and we all contributed. And it is it's a comprehensive and simple guideline that can be followed by any of the all kind of healthcare providers. So each unit should have its own protocols to ensure that the caregivers give a uniform care to their patients when it comes to postpartum hemorrhage. We also found that the having checklists or it can be taken as a work aid also in the workplace. If a postpartum hemorrhage happens, when a team is involved with in the management of postpartum hemorrhage, having a simple checklist can improve the quality of care. So often we miss certain things, whether to give this, whether to send this test, whether to involve the senior consultant. So using a checklist has helped in many places. So we try to adopt, or we try to use this checklist in our unit whenever when we encounter an bleeding patient. However, it is difficult because although it is easy to tell, we often forget because we are not geared to this type of practices. So we should often remind them, we should follow it up, and we should give a good leadership to improve the quality of care. So I talked about prediction and identifying risk factors, and modification of the care pathway, and readiness in the unit, and readiness of the providers, and importance of guidelines and checklist. So when it comes to readiness, we should have the sister or the in-charge nursing officer should check whether the kits and supplies are available. We often encounter now these days, we may, we run out of stock very frequently. So it is our duty to make sure the essential or emergency care, the drugs and the supplies are sufficient and ready for that, because we never know at what time we are going to have a nightmare. So as Prabodhana mentioned, when it comes to prevention, one important area is active management of the third stage that we have discussed, and detection. Often a postpartum hemorrhage is missed. Obstetric bleeders, we often diagnose in the late stage, and we have frequently near miss reviews show frequently we have started treatments after the golden hour is over. So when there is a prediction of blood loss more than 500 milliliters, or despite the third management, if the woman is having brisk bleeding or rising pulse rate, or blood pressure is falling with other symptoms, we should initiate aggressive management protocol. So recognition of excessive bleeding and targeted examination to determine its causes is also important. These are some of the quality indicators when it comes to the management of postpartum hemorrhage. So each unit should ensure that these points are, or auditable standards are maintained. Okay. So, and in developed countries, one of the important aspect of management or detection of postpartum hemorrhage is that they make sure they estimate the blood loss almost correctly by weighing the swabs, or weighing the blood that was lost at the time of delivery. It is the duty of the midwife or the nursing officer, and they are accountable for that. However, in our setting, it is very difficult. So we often depend on visual estimation. Visually, we estimate the blood loss, and we all know that it leads to a lot of problems. Visual estimation we often underestimate the blood loss. However, with effective training and with using of visual aids in the, displaying these visual aids in the labor rooms or in places where we encounter postpartum hemorrhage, helps a lot, and it improves the preparedness of the staff as well. In our ward labor room, we display this the set of pictures to help the nursing officers and midwives or even the doctors to improve their assessment. And also we found that we conducted a training program, and we have done a pre-test and we did a post-test, and this experience shows that regular refresher training or even simple methodologies to follow or train the caregivers improve the accuracy of the visual estimation of the blood loss. So, and also this table, I took it from the Liverpool Medical School's training program that we conducted through Family Health Bureau that time. And we often, that key important factor that was emphasized was, shock. Or we often, we often forget that healthy adults, healthy or pregnant women, they don't show the signs until they lose about 2 liters. So when we pick up a shock or patient with shock, we have, lost at least 30% of the blood volume. So that is one of the important area that we need to address when it comes to, provision of good care to obstetric hemorrhage. So again, as I said, this is one of the important areas that usually when they lose about 1 liter, we pick up women with either symptoms that they are in early shock. So we have to resort to aggressive fluid management. And sometimes tachycardia can be the earliest sign, that can be the only sign of women who are bleeding. So we need to we need to approach them with a target to identify the etiology. Again, we often miss when it comes to preparedness of the trainees or the preparedness of the caregivers. We often, we lack that knowledge, or we don't use these indexes. Shock index is one important area. The knowledge of shock index improves the management of postpartum care. Okay, when it says shock index is heart rate divided by systolic blood pressure. If it is more than 9.9, that means they are in shock. And also rule of 30, we often, if the woman's blood pressure, hematocrit or pulse rate is increasing by 30% or by 30, or systolic blood pressure drops by 30, or hematocrit falls by 30%, that means she has lost about 30% of the blood volume. So they are in moderate to severe shock. So I think Prabodhana, again, he highlighted some important key steps in the management pathways. Workplace-based training in obstetric emergencies is important. We have to have, even at any level, the trainees can, organize drills. Trainees can organize small workshops to improve enhance the knowledge of the caregivers. And also we should not forget the fact that, we should pay attention to an availability of the essential equipment as well. You have to see Bakri, again, sometimes when you want a Bakri, sometimes it may not be there. So likewise, postpartum hemorrhage kit should be organized and checked time to time. So the golden hour. So when it comes to, this is one of the auditable standards, actually, whether how many percentage of women were correctly treated within the golden hour is one of the auditable standard. And when it comes to management pathways, we have to focus on communication, resuscitation, looking for etiology, and monitoring and continuing treatment. All these things should happen hand in hand, it should happen together. Or, these are some of the key areas that we should focus in the management of postpartum hemorrhage. And it involves a lot of teamwork and, anticipatory clinical practice, and having a good guidelines and reinforce it. When you have a guideline, you can't keep it in the folder. Unfortunately, even we have seen that, in developed countries, even the consultant who authored the guideline checks the guideline frequently to refresh their knowledge. So it is very important. There are some simple tools, if you think having a big guideline is cumbersome, small care pathway or small protocols, adapted to your setting can help a lot to improve the care. Right. So we did a study on women who had postpartum hemorrhage or major obstetric hemorrhage due to placenta accreta. And we found that most of them had severe psychological or post-traumatic stress disorder. And we have often forgotten their experience. They are going through a traumatizing experience. We often forget the fact that we don't debrief them. We don't involve their families. We don't tell them what happened. We don't educate them. So this is a major problem. And most of the women who were involved in this project, actually, when we were doing the retrospective analysis, we found they had lots of manifestations of postpartum post-traumatic stress disorder, and one woman had suicidal thoughts as well. So we had to immediately refer them to psychiatrists. So we often forget that when it comes to the quality of care, we should always remember, we should give them the best experience as well. We should tell them what happened. We should communicate with them, and we often forget that fact. And also, to improve the quality, as I said, we had lots of key standards or auditable standards. We should make sure that these things happen regularly. So we should do audit cycles, and we can do near miss reviews time to time to enhance the knowledge and to improve the preparedness in the unit. So again, this is the tool, audit tool that we used in our unit, actually, to assess the postpartum hemorrhage. And we found that still the care needs to be improved, and we have had areas in which the treatment given was substandard. So we have, because of this, the gap only, we started those checklists, guidelines, and we had some training programs. And we hope to do the audit cycle again to see whether it has made any impact on the care and as well as the outcome. So I think I'm going to conclude. So I just wanted to inform you, highlight the quality of care is not only giving the best care, we should also give the best experience to the patient as well. So provision of care, experience of care, combination of both, this will lead to good improved outcomes. So again, we may lose Bakri. Sometimes we may not get Bakri in future. So condom catheter may come back to practice. When we were senior registrars, along with the medical student, we just improved the condom catheter to see whether to develop a draining channel. Just if you have time, go through this. So that concludes my presentation. I just wanted to highlight the fact that, knowing the evidence-based care, or knowing the management options or medical management, whatever the management options, is not enough. We should be ready, we should be prepared, and we should give the evidence-based practice as well as improve the experience of the patient as well, in order to improve the quality of care in patients with postpartum hemorrhage and to save lives. Thank you.
Do we have any questions from the audience? Looks like you were very clear and everyone understood. Let's just wait for the chats to see whether something is up.
I think I'm Janaki here. Uh, I'm Janaki here.
Yeah.
Just want to say, I mean, you are quite correctly said about stick to the evidence-based practice.
Yes.
Not only for the management, for example, like things like, say, the induction of labor, misuse of induction of labor, or sometimes we have seen some PPHs happening because of, using glandine, and then after that, like without waiting for waiting for the 6 hours, introducing syntocinon and going into precipitated labor and going into PPH, and then misuse of misoprostol causing PPH in miscarriages. And I think since we are doing this confidential inquiries into maternal deaths, I think that is the correct time to address that issue as well. I mean, not only the management of PPH, I'm just asking from you whether that is also an important issue, isn't it?
Thank you, madam. Yes, it's an important thing. Yes, definitely. It's not only management of postpartum hemorrhage, it's also management of other aspects when it comes to quality of care. Again, provision of care in the routine practice as well as in emergency care. So if you mess up the routine practice, you will end up in having problem in the emergency care as well. So that is interrelated. That is, I think, when we have to be very careful when we select patients for induction. We should, that leads to a higher rate of induction of labor is linked with other complications as well, postpartum hemorrhage. Yes, we actually, as part of my PhD project, we correctly identified that problem, and we have done an audit of induction of labors. Again, we have developed a checklist, we have developed a protocol, we have developed a patient information leaflet, and we are very strict about induction of labor. We have a large database. Now we have about 10,000 patients data, and we have done publications regarding induction of labor, and we correctly induce at 41 weeks only. So we are very clear. Our doctors are following the protocol, and actually this model can be followed in other units as well when it comes to induction of labor. Thank you, madam. Thank you for giving that opportunity.
Yeah.
Thank you.
Thank you, Rishad, for your interesting talk on improving the quality of management in PPH. We will now move on to our last lecture for today. This is by Dr. Ayesha Abewardena, who will be sharing her expertise on transfusion support in postpartum hemorrhage and its current trends. Dr. Abewardena is a consultant transfusion physician and head of the Department of Transfusion Medicine at Sri Jayawardenepura General Hospital. She obtained her MBBS from the University of Colombo, an MD in Transfusion Medicine from Postgraduate Institute of Medicine. She completed her overseas training at the prestigious King's College London and specialized immunohematology training at International Blood Group Reference Laboratory, Bristol. Over to you, Dr. Abewardena.
Thank you, Shamun, and good evening to all of you. First of all, I would like to thank the Council of SSCOG for giving me this opportunity to talk to you on current trends in transfusion support in PPH. Before moving to the topic proper, we'll recap our knowledge on the changes in hemostasis at term, coagulopathy in PPH, and the strategies for assessing hemostatic impairment during PPH, so that we'll have a better understanding on the transfusion support in this clinical setting. So, as you all know, the level of all procoagulant factors except factor 11 are increased at term with certain factors like factor 8, fibrinogen, and 1 Wilburn factor increasing to levels more than 100%. And when we come to natural anticoagulants, protein C just remains normal or unchanged while protein S come down. So you can see this is a prothrombotic state near term. So this has a major implication on our blood testing as well, because our PT and APTT, which are the main hemostatic tests, would have a shorter value because of this procoagulant state. So our baseline would be shorter than what we normally see in our normal non-pregnant population. So that unless we have a considerably large bleed, these tests won't be abnormal also, right? And our plasma volume increased by about 40 to 50% at term. And the uterine blood flow goes up to about 700 mils per minute at time of delivery, right? And though there's absolute increase in the platelet count and the red cell mass during pregnancy due to this exponential rise in plasma volume, you may see a relative thrombocytopenia and an anemia, right? So in addition to those, the local activation of coagulation and fibrinolytic pathways at the time of placenta separation again plays a role in the hemostasis at the time of delivery. And some studies show that this fibrinolysis comes back to normal within hours, but recent studies show that it may even last fairly long, right? I think so. The coagulopathy in PPH could be due to pre-existing coagulation disorders, like in your congenital coagulation disorders, and also could be related to pregnancy and delivery. So, as per the current literature review published in 2023 by Hoff and others, we see when you see the causes of PPH, your common 40s, coagulopathy or the thrombin amounts only to about 1.9%. But what we have to realize is, whatever the original cause, if the bleeding continues and not addressed properly, it will lead to a coagulopathy, which may subsequently, exponentially rise to a rate of hemorrhage. So the coagulopathy here, I think you can see. The type, severity, rate of onset, and the mechanisms of coagulopathy depends on the etiology of PPH. So as you all know, most cases of PPH, which are due to uterine atony or trauma to genital tract, in spite of having a fairly large blood loss, will have early coagulopathy is unusual. But again, you have to keep in mind, if the diagnosis is late or there's an underestimation of blood loss, this may have a apparently early onset of coagulopathy, right? In contrast to, say, a situation like placental abruption, which will lead to quite severe and rapid consumptive coagulopathy, even with a milder blood loss at the beginning, what we see. And HELP syndrome or PT or amniotic fluid embolism would have a severe and rapid onset of DIC at the beginning, right? So the mechanisms matter on the etiology with the PPH. So in addition to those, the local activation of fibrinolysis at the time of placenta separation, again, could be aggravated or due to the tissue hypoxia during a severe PPH episode, which may also contribute to unstable clot formation in this scenario. So this is a slide from the review from Collins and Collins published in 2015, which just show the same thing I told, where you may see uterine and attenuate genital tract trauma may cause late coagulopathy. And DIC in this setting is quite rare, right? With large bleed, it may lead to either dilutional or consumptive type of a coagulopathy. In contrast, in placental abruption, you may see early coagulopathy, sometimes even before the blood loss is observed, and it mainly a consumptive type of a coagulopathy at the beginning. And amniotic fluid embolism and preeclampsia both causes quite early coagulopathy, and you see amniotic fluid embolism, its main cause of coagulopathy is DIC, right? So with all this in mind, we appreciate, it'll easy for us to appreciate that the hemostatic changes in PPH differ from other types of bleeding in non-pregnant populations, such as trauma or surgical bleed. So coming into strategies of assessing hemostatic impairment, obviously, our first strategy is the clinical observation and evaluation, as my two previous speakers spoke about. And obviously, when you start your red cells, even in the transfusion management, you start red cells depend on your clinical observations and clinical evaluation in such a case. But then comes your standard laboratory test. For hemostasis, it's mainly platelet count, PTA, PTT, and fibrinogen levels. So the good thing about them is they are quite widely available. But the problem with them is, as I told you, they are not very sensitive to an evolving clinical scenario like a PPH. So there are studies that have shown that PPA, PTT may remain mostly normal despite large bleeds up to about 5 liters. So they are relatively insensitive to this type of a rapidly evolving clinical scenario. And even the timing for this test, it takes at least 30 to 60 minutes for us to have a result. So those again warrant these tests not very suitable to manage a rapidly evolving clinical scenario like in case of PPH. So the third strategy would be point of care testing. So for the hemostatic monitoring, what test we are having is ROTAM and TEG, of which what we have in Sri Lanka is ROTAM. So this enables real-time monitoring of the coagulation status in a rapid bleed with a much faster results, where we can get our results within about 10 minutes, right? And it's provide us with information on the fibrinogen level, platelet function, coagulation status, fibrin cross-linking, fibrinolysis, and the results will imply specific interventions for immediate correction, which is what is needed in an acute scenario. And the basic test that we do in case of a PPH in ROTAM would be extem and FibTem at the beginning. And we would move to INTEM and HEPTEM only in cases where the extem and HEPTEM are normal. So I know you all know there's much talk on the fibrinogen level and the PPH. So prospective observation study published in 2010 reliably says that the FibTem amplitude of F5 can reliably detect a fibrinogen level of 2 grams per liter, which is your general cutoff. And there are multiple studies that have shown clinically significant low fibrinogen levels during delivery are found to be a good predictive marker for progression to severe PPH. So keeping those in mind, now we'll talk about the newer approaches in transfusion management in PPH. So as you all know, bleeding is initially controlled by timely obstetric measures in parallel with the resuscitation and treatment of anemia. So there's nothing much new on red cell transfusions over the last couple of years. I mean, you all know that red cells are used to maintain adequate oxygen carrying capacity in order to avoid tissue hypoxia. And generally you start your red cells or consider starting red cells when you're on clinical assessment. When your estimated blood levels is more than 1,000, like with continued bleeding. So what is the type of red cells you are going to use would vary from the availability, whether it's cross-match blood, uncross-match group specific, or uncross-match or negative, depending on the clinical urgency and the availability at that moment. So our main change in the transfusion management in PPH comes in the area in the management of coagulopathy in this setting. So now we are moving more and more toward point of care guided therapy, which allows us real-time monitoring of the patient and allows us to give a personalized care depending on the state of coagulopathy of the patient. Versus what we used to do was the ratio-based care supported by standard laboratory tests. So as you all know, and as we discussed earlier, the main issue with these protocol-based therapies are since they are being adapted from bleeding from other clinical settings, their suitability to use in obstetric setting is a bit questionable. And in practice, we have seen a lot of overtransfusions, especially pertaining to plasma and platelets, which leads to subsequent complications on fluid volume overload and even pulmonary complications due to unnecessary plasma transfusions. We'll discuss about point of care test guided hemostatic therapy a bit more, since it's what we are going to talk today. So the basic concepts of point of care testing is to do the correct intervention with the correct dose at a correct time in the correct sequence, right? There are multiple comparative studies that had shown POC-guided therapy in women with PPH resulted in less blood product requirement and improved patient outcomes compared to those without guided therapy. So I'm quite sure you are quite conversant with the normal Rotem graphs and algorithms, but I just thought of showing you in a PPH setting, we are mostly concerned about the clotting time, A5 and A10, basically A5, and the maximum lysis, which indicates a fibrinolysis. But what you have to realize is the normal values in obstetric setting is much different to what you see in a normal reference ranges for the normal population. So this table of reference values were taken from King Edward Memorial Hospital, Perth, which is further endorsed by the recent publication by Ronenson and others in 2022. If you can see here, the small box below shows the normal reference ranges for the normal population. So as we discussed earlier, pregnancy is a procoagulant state at delivery. So if you see properly, we are mainly concerned about the extem and fib-tem at the beginning. So the extem CT, or the clotting time, which gives us the indication of the adequacy of coagulation factors and presence of anticoagulants and things. You see the CT in extem in pregnancy, that normal reference range is from 31 to 63 seconds. In comparison, do we have a point? In comparison to a non-pregnant population, where the CT is 43 to 82, which is, so the CT in pregnancy, at term would be much shorter than non-pregnant population. And I hope you can see it. And even the amplitudes, clot amplitudes, the A5 in extem, the reference for pregnant population, obstetric reference range is 41 to 64 millimeters compared to non-pregnant reference range from 33 to 52. So a normal thing in a non-pregnant population would not be normal or adequate in a pregnant scenario, at term. So but always, and even the maximum lysis in a non-pregnant scenario, we take less than 15 as the cutoff point, whereas in pregnant populations, in extem it's less than 5% and in fib-tem it's less than 10%. So I want you to emphasize the point that when we are taking ROTEM cutoffs, we have to always refer to the obstetric values rather than the normal ROTEM cutoffs that's used for the general population. So keeping that in mind, we'll move to the current ROTEM PPH algorithm, which is published in 2019 by Gerlinger and others. This is the latest algorithm we are using and in practice. This has small changes from the previous algorithm proposed in 2015 pertaining to the cutoffs and the target levels concerned. So, and these are rapidly evolving things. So, I mean, what I discussed today may change in another couple of years. So, if we go through this in a bit of detail. So, this algorithm starts with a clinical scenario, that's a bleeding. So normally what happens is when there's a estimated blood loss of about 1 liter, you will start sending your blood sampling, start think of ordering red cells. So at that point, send us a sample for ROTEM as well. Do ROTEM. So this would be the baseline. So at that point, you may even consider giving tranexamic as per the recommendation of the woman trial, where they say that giving tranexamic within 3 hours would be beneficial in reducing mortality in the pregnancy PPHs. So once we get once we get the sample, the first 2 tests that we do would be the XTEM and FIBTEM, as I told earlier. So normally the results are available by about 10 minutes. So in the XTEM, first we see is the clot amplitude at 5 minutes. So if our clot amplitude in XTEM is less than 35 millimeters, then first we look for the FIBTEM CT value or the clotting time. So if the FIBTEM clotting time is more than 600, that's a flat line in FIBTEM usually. So XTEM CT less than 35 with a flat line in FIBTEM indicates hyperfibrinolysis. So if you see this, obviously we have to go for tranexamic as the first line of therapy. So if you have given the tranexamic previously, you may repeat it after 30 minutes. Otherwise, you may start your tranexamic acid bolus over 10 minutes and if necessary to repeat. But on the other hand, if the XTEM A5 is less than 35, but the FIBTEM CT is fairly normal, then we look for the FIBTEM amplitude at 5 or FIBTEM A5. So if the FIBTEM A5 is less than 12, that indicates hyperfibrinogenemia. So in this case, what we have to go is to go for fibrinogen replacement. So which could be done with precipitate, fibrinogen concentrate. FFP is not the mode for fibrinogen at the moment. I mean, you all might be very well knowing about it. Though it contains fibrinogen, it takes large volume to make the adequate amount of displacement. So what we commonly use in Sri Lankan setting is precipitate. So the target here is to make the XTEM FIBTEM at least to 16 millimeters. So to do that, there's this dose calculation chart. I don't think you can see it very clear here. So if say your initial FIBTEM A5 is 12 millimeters and you want to make it 16, that's to increase by 4 millimeters. You may use 1 adult pool of cryoprecipitate. That's 10 units of cryo. So if your FIBTEM A5 is 8, to make it 16, you need to increment by 8 millimeters. So you may need 20 units of cryoprecipitate. So that's how you calculate the dose of cryo depending on the FIBTEM A5 levels. So just to highlight this point, because we are quite concerned about the fibrinogen in pregnancy, OBS2 trial has very well, in its conclusions said, this was a double-blind randomized control trial, multi-center trial. So it has well, in conclusions, it has very well concluded that the fibrinogen replacement is not required. This FIBTEM A5 is more than 12 or gross fibrinogen levels more than 2 grams per liter, which level would be adequate for hemostasis in PPH. So this is just to show you that, you might see in some clinical scenarios, we just go on giving cryo, which is not really necessary because if the FIBTEM A5 is more than 12, it may not really benefit the patient by giving cryo at that point. because that amount of fibrinogen would be adequate to maintain the hemostasis. And just a small point from that study, I just want to put in here, because they have noted that in about 90% of the cases in their study, FibTem-A5 remained above 15 millimeters with normal PTA-PTT, and the bleeding was controlled without any hemostatic support. Okay, coming back to our algorithm. So still we are going with XTEM-A5 less than 35 millimeters. So this is the algorithm we go down if it's not the previous case. So if the FibTem-A5 is not less than 12, then we would think, then is the scenario where this is a platelet deficiency, because the XTEM-A5 amplitude is depicts the deficiency of either fibrinogen or platelets mainly. So if the FibTem denotes the concentration of fibrinogen. So if the FibTem amplitude is less than 12, it is a fibrinogen deficiency. If it's more than 12, it's a platelet deficiency. So then you have to go for replace platelets. So how much platelets are we going to give? If the XTEM-A5 is between 25 to 35, we would give 1 adult pool of platelets, that's 4 units. But if the XTEM-A5 is between 25 to 15, you may go straight away for 2 adult pool of platelets, that is 8 units. And actually, if the XTEM-A5 is even lesser than that, less than 15, it denotes both fibrinogen and platelet deficiency. So you may give both fibrinogen, cryoprecipitate 10 units plus the adult dose of platelets. So so if it is not so, and if the XTEM-A5 is more than 35, then we look into the XTEM clotting time. So you would have seen the sequence, it started from correcting the hyperfibrinolysis, then the clot firmness. Now we are talking about the thrombin generation, right? So if the XTEM CT is prolonged with FibTem-A5 more than 12, that is fibrinogen levels are adequate. If the XTEM CT is more than 80, if that is prolonged, then we think it's a clotting factor deficiency. So we, for this scenario, we may go for FFP, 12 to 15 ml per kg. You can use PCC if it's available. But there's a point I want to highlight in this, at this level. XTEM CT is affected by fibrinogen as well. So if the XTEM CT is say prolonged, but it's less than 140 with low fibrinogen, where the FibTem-A5 is less than 12, in such a scenario, we don't go for FFP straightly. We will correct first with fibrinogen and repeat the ROTEM to see whether it has corrected. Most of the time, this prolongation in XTEM CT is due to fibrinogen. So it will be corrected with fibrinogen alone, and we don't have to give FFP. But so that's why we say we treat this only if the FibTem-A5 is more than 12. And but if the FibTem-A5, even if the FibTem-A5 is less than 12, if the XTEM CT is more than 140 seconds like, then it indicates dual deficiency. So in such a case, we would go for cryo plus FFP together, back to back, before going to the next level of intervention. I hope you are clear on that. Right. So now we come to scenario where XTEM CT is also normal. And so in that case, the FibTem also had been normal because now the amplitudes have. Okay, so in such a situation, then only we think of doing on INTEM and HEPTEM. So then we run, if our initial values up to A5s are normal in XTEM and FIB, then we start loading INTEM and HEPTEM. And if the CT is in INTEM is prolonged, that's more than 240 seconds, we look for the ratio of the CT of INTEM and HEPTEM. So if the CT INTEM-HEPTEM ratio is more than or equal to 1.25, it indicates a heparin effect. So such a situation, you have to give protamine to correct it. It will not be corrected with clotting factors like FFP or anything. So, but if not so, then we will have to think of an intrinsic pathway coagulopathy or an acquired hemophilia type of situation. So in such a case, you would go for, you would first try with FFP 10 ml per kg. If not correcting, and if you are thinking of an acquired hemophilia type of a C2, we will go for recombinant factor 7A, right? So then comes the down arrow saying no. So in that case, your all the coagulation, all the ROTEM parameters that you have done, intem, extem, FIBTEM, and HEP, all had been normal. So, but still, if the patient's clinical bleeding is ongoing, at that point, there's no coagulopathy at the time of sampling. But if the clinical bleeding is ongoing, we have to repeat and see and look for evolving coagulopathy. Because, though there had been no coagulopathy at the beginning, doesn't mean with the subsequent bleed, it may not go into a subsequent coagulopathy. So it's very important that if you see a normal ROTEM at the beginning with all 4 paras, still if the bleeding is clinically significant and continuing, that you need to repeat it. Repeat is a new sample. So this is the ROTEM guided pathway for hemostatic management, what we use currently in case of PPH. So this is just to show an algorithm incorporating the ROTEM guided pathway by King Edward Memorial Hospital. Of course, you will have to correct your, pH, correct your acidosis, calcium level should be more than 1.1 per millimoles, and correct hypothermia and all those factors affecting coagulopathy in addition to the blood and blood product replacement. And okay, so upper part you can see, I suppose. This is again from the University Hospital's Plymouth PPH algorithm incorporating ROTEM. So again, here you will see they after the estimated blood loss of 1 liter, they start ordering the first 2 units of red cells and sending the investigations. So at that time, with the ROTEM, they go for first 4 packs of red cells and go for the ROTEM guided pathway. So though I'm just showing you some international PPH algorithms, even in Sri Lanka, there are multiple hospitals that do use ROTEM guided PPH algorithms. I think most of you all must be familiar with the algorithm that they use at Castle Street, I suppose. They had been using it for some time. There are certain changes from that, the initial algorithm that was used at Castle Street, because the original ROTEM cutoffs and targets, which was published in 2015, has changed a bit now. So I hope it had been updated. This is a rapidly evolving thing. With new evidence coming up with new trials and new evidence, it changes over the time. So even what I told you today, as I told previously, it may change over the next couple of years. I'm not going to talk to you on ratio-based therapy because my topic today was to talk about the current trends. But just a small point I want to highlight there. When you are using ratio-based therapy supported by standard laboratory tests, your target for platelet count, because platelet count above 50 per 10 to the power 9 per liter is adequate to maintain hemostasis in PPH. But you may see, if you see a lot of PPH algorithms, they say to order platelets when the count is less than 75. That's across the world. In a lot of algorithms, you see that. The main reason for this is a lot of those centers don't have platelets in hand at their blood bank at that point. So when to order your platelets would depend on the local logistics on your institution, whether if you are having adequate stock of platelets, plus if your blood, if you say that distance to blood bank and the theaters are close, not very far, you may stay stay for some time more, and you may request platelets at a lower level than 75. But if your logistics are such that your station doesn't store platelets or don't have platelets on adequate numbers, or if your distances are large so that you can't get them on time, in such case, it's better that you order around 75. I just wanted to highlight it because sometimes I tend to over transfuse. It's not that you want to keep it above 75, you have to keep it above 50, but to avoid delays only you order at 75. So it depends on your local logistics. That concludes my lecture. So in summary, hemostatic impairment in pregnant population is different from bleeding in other clinical settings. And the type and rate of onset of coagulopathies differ depending on the underlying cause. And early recognition of abnormal coagulation is crucial in PPH, and hemostatic support should be considered simultaneously with other strategies. And there should be clear local protocols and standardized algorithms on how to manage med hemorrhages. And where available, point of care testing should be used to enable more effective and targeted hemostatic therapy in PPH. So thank you for your attention. I would like to take any questions if they have any.
I'm Dr. Janaki again. Just want to ask,
Yeah.
isn't it necessary to give that massive transfusion pack even if you have rotem available? Because sometimes it takes some time to get the rotem reading and those things.
Yeah, madam. I
No,
mean, it's
yeah.
something like, yeah, I understand your situation, madam, because in our local settings, sometimes the availability of rotem takes time. So until such time, obviously, we have to go for our ratio-based resuscitation as per the massive transfusion protocol. But earlier you go for the rotem, it's better so that you avoid unnecessary transfusion, especially of plasma components, which subsequently lead to a lot of overload and unnecessary transfusions.
Yeah, okay.
Madam, yes, at the beginning, till you get whatever your results, you will have to go for ratio-based therapy till you get your results.
Okay, thanks. Thank you.
Thanks, madam. Any other questions? No questions, no? Yeah. So with no questions, I think that's
Any questions from the audience? Jatish, do you have any questions?
Can I ask another question?
sure.
I'm Janaki here. Yeah.
Yeah, sure.
Just want to ask, like, now there are some situations where when you do the rotem, we understand there is some problem with the platelet. But if the patient is not actively bleeding, my understanding is you don't have to give platelet
Yeah,
transfusion.
definitely, very correctly, madam.
Yeah.
If the patient is not bleeding, these algorithms start with the clinical scenario of bleeding. So if the patient is not
Yeah.
bleeding, you don't need to correct, because it's not the numbers that you are correcting, it's a patient whom you are treating. So you don't need to correct any numbers as long as the patient is clinically not bleeding and stable. Very correctly, madam.
Okay, thank you.
Thank you, madam. I hope it's done. Thank you.
Thank you very much, Dr. Aisha Abewardena, for your valuable insight on transfusion support in PPH. We have come to the end of our webinar for today, and I would like to deliver the vote of thanks on behalf of the Council of 2023. Once again, it's my great honor and privilege to propose this vote of thanks for the hybrid lecture, which is our fourth in the series of webinars that we have organized. So first and foremost, I would like to extend my sincere gratitude to our three speakers today. Dr. Prabodhana Ranavira, who's a consultant obstetrician and gynecologist, Dr. Rishad, also consultant obstetrician and gynecologist from the Faculty of Medicine, University of Colombo, and Dr. Ayesha Abeyvardhana, who was our invited lecturer, who gave us the invited lecture on transfusion support, who's a consultant transfusion physician at Sri Jayawardhanapura Hospital. I thank the three of you for your valuable time and for sharing your expertise with us in optimizing the management of PPH. Also, on behalf of the college, I'm very grateful to our sponsors once again, Mr. Gihan Lochanasan, Country Head Bharat Serums and Vaccines Limited, India, and also Mr. Praveen Herath, who's the business manager, Sioka Health Private Limited, for sponsoring our webinar today. In addition, I'd like to thank the staff of our college who have always been very supportive and rendered their assistance in coordinating with today's event. And also to the participants gathered here physically, and to those who joined with us online. I hope today's lectures that were delivered by our three eminent speakers were useful in updating your knowledge and the management of postpartum hemorrhage. Finally, I would like to thank everyone who helped in many ways who I haven't mentioned, especially my team at Sri Jayawardhanapura General Hospital for rendering their support towards this event today. Thank you once again, everyone. And please join us on the ground floor. We have arranged some drinks and some refreshments for you this evening.